swear I turned that beeping noise off, but obviously I didn't. It's taking a while to admit folks. There's a lot of them. Good afternoon, everybody. We are admitting folks from the lobby. There are a lot of folks joining us, so give us a couple minutes to make sure everybody in the lobby is with us. Lisa, we only have an hour, so I say we get started. We're 3 minutes after, and I will continue to admit folks from the lobby as we go forward. And if you could just give me a signal when you need me to change the slides.
All right, great. So welcome everybody. My name is Lisa Job Shields. I'm the Behavioral Health Division Director here at DMAS. And we are so glad that you came to join us today for us to provide this update and kick off a public comment period. We've been uh, so appreciative of all the input you've given so far through the surveys, and we'll report out on that today. And we're hoping that today's webinar leads to the next phase of discussion. We're now 6 months into the 2-year project. So without further ado, I'm going to pass it to Laura to tell a little bit of information about the webinar today.
Yeah, sorry about that lovely beeping noise we have. Can't figure out how to turn that off. Good afternoon, everybody. My name is Laura Reed. I'm the Behavioral Health Senior Program Advisor here at DMAS, and a couple of things about the webinar today. It is being recorded, and it will be posted to our YouTube channel as soon as I can get it on there, hopefully in the next 24 hours or so. All participants are muted and your cameras are off for bandwidth reasons. The Q&A function has been disabled. The chat is open, but we will not be monitoring the chat for questions. You will see in the chat that there is a link to a Microsoft form. So if you have specific questions about the content of our webinar, feel free to use that link to submit your questions or comments to us. We may have some time at the end of the webinar to answer some basic questions. We may not, it just depends. So we'll figure that out as we go. Also, there's a link in the chat to the document that we're going to be talking about today, which has gone up for public comment today until January 3rd. Our current speakers today are Lisa Job Shields, the director of our behavioral health division here at DMAS, myself, Heather Norton, the Deputy Commissioner for Community Services at the Department of Behavioral Health and Developmental Services, and Dr. Alexis Aplaska. She's the Senior Clinical Advisor for the Right Help Right Now Behavioral Health Transformation at the Secretary's Office, as well as the Chief Clinical Officer for the Department of Behavioral Health and Developmental Services. Thank you all so much for coming to speak with us today. All right, so I'm going to hand it, I believe, over to Heather.
Thanks. Thank you, Laura.
Mhm.
So we're here today to talk about Medicaid behavioral health redesign. If you've heard this presentation before, you know about the four core issues and the four priorities of behavioral health redesign. The first really focuses on service definitions not having been updated to reflect evolving evidence-based practices and trauma-informed principles. And so our efforts around the first redesign priority is to redesign services that will represent an integrated continuum of care, meeting people's needs in the least restrictive setting across the lifespan. The second area of concern and redesign priority is around access to community rehabilitative services, which require a serious mental health diagnosis, which creates gaps for individuals and families who are not met by whose needs are not met by outpatient services, but are not at risk for out of home placement. So and that our service intensity does not vary except for lengths and units of treatment. And so a second priority for redesign is to really focus on services that will represent an integrated continuum of care, meeting behavioral health needs in least restrictive settings, and using the best available evidence-based practice. The third issue is that our services were designed prior to transitioning to a managed care delivery system, as well as some of the changes that have occurred at the state and local governmental structures. And so our third priority is to really define medical necessity criteria for improved communication and streamlined process for managing services. And then to make sure that, of course, data is shared more appropriately and that we are all talking about the same things. And then finally, the fourth core issue was really about the workforce crisis and making sure that individuals are practicing at the top level of their scope. So making sure that LMHPs, QMHPs, and the newly identified behavioral health technician position are integrated into the core services, and that we're utilizing those positions in a team-based care model so that we have appropriate caseloads and supervision for all individuals. Next slide, Laura. And so we are, I'm going to hand this over to Laura, who's going to give some updates on stakeholder engagement and input, design decisions for public comment, and then the next steps related to behavioral health redesign. Laura?
Thank you, Heather. So really since July, which was the last time we had a public webinar about our project, it was the launch of this project. We've really been concentrating on stakeholder engagement. And this slide really talks about all of the stakeholder engagement that we have been doing over the last couple of months. We've had a huge emphasis on that, really wanting to hear from our stakeholders, from providers and advocates to the individuals that we serve, our members, and our health plans, as well as families and caregivers of our members as well. So we have done a lot of engagement over the last couple of months. We have done several surveys, one for providers, one for the schools concerning therapeutic day treatment, a survey for youth, family members, and our adult members. And you can see sort of how much response we got from those surveys. We were actually really happy with the response that we got. We got a pretty hefty response for all of our surveys and got some really good feedback. We also did, we've held 2 informational webinars, and we did some in-person and virtual listening sessions. We did 2 listening sessions for advocates, 2 listening sessions that were in person for members, 1 that was virtual. We did several provider conferences and listening sessions at those conferences. as well as a listening session for our MCOs. So right now, we are analyzing all of that feedback that we got. We got some really great feedback. The next slide really talks about the themes that came out of those engagements with you all and our other stakeholders. And really the primary themes were number one was a lack of transportation and a lot of concerns with transportation in general, including public transportation as well as Medicaid transportation. The need for a longer term, what we're calling a maintenance service. So a service for individuals with serious mental illness that is a longer term service that helps them remain in recovery. A concern about lack of workforce, the need for our services to have acuity tiers, so not just be for individuals with intensive needs, because we need to be, we need to be as preventative as we can. There's a lot of support for peer recovery support specialists and the services they provide to be embedded in the new services and support for that continued, that continuation of that service. There's a need for more services and preventative services to provide a full continuum of care, which we are hoping that this project meets some of that need as well, and the need for standardization of processes and requirements. So that was really the themes across all of the stakeholders we talked to, and we're looking at taking that feedback and embedding that feedback into our project as we go. So I think I'm going to hand it over to Lisa.
Yep, that's right.
Okay. All right.
Thank you, Laura. So essentially what we have today is there's kind of 3 areas where we feel like we do have some tentative design decisions that we, are putting out there to get your reaction to. These are the 3 areas. So I'll start talking about the first, and I'll pass it to Dr. Aplaska, and then we'll switch back to me. So you can go ahead to the next slide. We'll go on and start talking about the standardized assessment, level of care model, and person-centered treatment planning requirements. You can go one more, sorry. Great. All right. So essentially, this is kind of the information that we wanted to share about these 3 areas. So number one, the need for a level of care model. And so the next slide will be a draft. It's a very early draft, but did decide that it made more sense to share it just so you could kind of visualize what it is that we're talking about. And essentially the idea is that it would be a standard level of care model, and that by understanding what level of care was appropriate to an individual, there would be sort of different services available at that level of care. Not a single service at the different levels, but more the general level of care and then sort of an array of services that would be available. And, obviously very connected to the idea of a level of care model is the need for a standardized assessment. We started off looking at a number of assessments, but once we did just a little bit of research on the different options, the CANS and the ANSA did come forward as what most likely made the most sense in terms of something that would be appropriate for these rehabilitative services, that has a child version, the CANS, and an adult version, the ANSA, and also that is not, doesn't cost sort of for every time that you do the assessment, you're not paying a fee for it. So as of right now, that is the only assessment that that's really risen to the top that might make sense for this. At this time, we are tentatively thinking that we would kind of start planning for that, but it most likely would not go into effect right on that, July 1, 2026, when the services would change. Probably the assessment might take a little bit more time to implement, but we're not quite sure. And did want to mention that you all are probably tracking that we've been in the process of developing an 1115 serious mental illness waiver application. And if we do move forward with that, it'll be required that we have a statewide standard assessment and level of care model. So again, there would be this sort of another reason to do something like this also. And then the third part is person-centered treatment planning. And the general idea is that through the redesign, we would have stronger processes and set expectations regarding plans being shared across entities. So same thing with the assessment. We would need to find a way to share data from the assessment so that an individual isn't getting the same assessment multiple times, right? So that's one of the trauma-informed principles that we want to adhere to. And so we don't know exactly what that would look like. Again, year 2 of this project will be all about planning for implementation, but something to make sure that the health plan who is paying and monitoring the services, as well as the provider, the member, and if there's multiple providers involved, that everybody would have access to that information. And also that if progress is not being made on a certain service and someone is in the correct level of care, that providers would need to recommend a different treatment approach to make sure that everyone is in a service that makes sense and is actually helping them progress towards their goals. You can move forward to the next slide, Laura. Right, so again, this is an extremely early draft, but did decide to share it just so that you all could visualize what it is that we're talking about when we say a standard level of care model. So as you can see, there's 6 levels here, and I'll start at the bottom. So level 1 is mild to moderate mental illness. And as you can see, this has a number of our services that are already in our benefit. So the crisis services, peer recovery supports, outpatient therapy, med management, things that are sort of available across the benefit. We are looking at some potential specialty outpatient rates that we haven't gotten there in the rate study yet, but if we were to do that, they would be available there too. But essentially the point with this level 1 is really it's a mild to moderate condition. And it would not qualify for the services that we're mainly talking about today. Moving up 1 level, there's sort of 2 different groups that could be considered a level 2. Number 1 would be intensive, mild, moderate. So the idea that, right, outpatient is not meeting the needs, but it might still be a mild or moderate condition, but just needs a little bit of a step up. And that's where you can see in the yellow, that's where you would start to have access to the services that we're going to talk about today. And then also coming from the other direction, someone could be at level 2 as a long-term maintenance, and they might have a serious mental illness or serious emotional disturbance, but they have supports in place, but they might sort of be, at a level where they're stepping down and down, and only at that level 2. Moving up to level 3, you can see throughout this presentation today, you'll hear us talking about level 1 and level 2 of these community-based rehab services. And level 3 is where you can really see that it can be a step down or it can be a step up, and both level 1 or level 2 might be appropriate depending on what the situation is with the member. And then as you get to these higher levels, so really 4, 5, and 6. You can see that the way that we're envisioning it, what we're learning from other states is there's really not a lot of difference in the range of community services that someone might need to have access to. It's sort of more in a way, the intensity of the service and the amount of the service and what the alternative would be. So you can see sort of level 4 would be that general intensive community treatment. Level 5 might be safety stabilization, so it might be like an alternate setting would be a residential crisis stabilization, all the way up to 6, meeting criteria for that inpatient, for an inpatient service. So the general idea at all 3 of these levels, 4, 5, and 6, is that we want to have a range of what we're calling wraparound evidence-based practices as a first-line treatment if someone meets criteria. So 3 of these we already have in our system: assertive community treatment, multisystemic therapy, and functional family therapy. But as you all know, the criteria to enter into those services are very specific. So people could be at that really high level of need, but not meet criteria for any of those services. So what we're thinking and proposing, we are looking at 2 more wraparound evidence-based practices through this study. We don't know if we'll be able to implement them, but the two that we are looking at are high fidelity wraparound for youth and coordinated specialty care for transition age youth and young adults. But outside of that, outside of those wraparound EBPs, essentially we're looking at this kind of intensive level of this general service, which is going to be, essentially everything that we're going to be talking about today. You can see we have a name. We have a sort of a general name. I think on the next slide we'll talk a little bit more about that. That's just a generic name that we're using for it: community psychiatric support and treatment, level 1 and level 2. So just wanted to share, again, this is a very early draft of a level of care model, but just wanted to show a visual of what it would mean for us to move to a level of care model. There would be an assessment involved, and there would be sort of agreement of which of these 6 levels someone is placed at, and then that would be tied to the services that they would be eligible for. So I think I have 2 more. Actually, I think I have 2 more slides, then I'm going to pass it. Actually, I think this is the one that I'm going to pass it to Dr. Aplaska for, to take us through the beginning of what these services are going to look like.
Thank you. So these are the design decisions for public comment. So the redesigned community rehabilitative service definition and structure. And then we'll take you through the agency level draft requirements, included activities, and activities completed by professional type, and we'll explain that more. And then the level 1 and level 2 services that Dr. Drope-Shields mentioned. So you'll see throughout the presentation, we're going to be using the term community psychiatric support and treatment. That's going to be a new term that we're using for this presentation. The term you're probably more familiar with is community mental health and rehabilitation services. And that's the focus of the services that are going to be part of redesign. So next slide. So this is highlighting the CPST services that would be the agency requirements for these services. So if you're familiar with the DMAS manuals, as I'm sure many of you are, have read them forward and backwards, you'll notice that at the beginning of every service manual, there is a section there that provides requirements for groups of services. And this is all that it does. So these are the agency level requirements. So these services can offer both tier 1, or both tier 1 and 2 rehabilitative services. They could be just for youth, adult, or both. They can be center-based, school-based, community-based, or both. So really broad locations and broad tiers. There is a requirement for these services to have a clinical director, meaning that person is licensed and available full-time. It will also include supervision requirements, including the hours of supervision and other requirements for licensed eligible, licensed, and non-licensed staff. It also introduces caseload limits for each staff level, including across agencies. So we know that's important. We want the supervision to be high quality. We don't want our staff to be and service providers to feel like they can do a good job for the new services that they're providing and the individuals that ultimately are receiving care. There's some requirements related to accreditation by either CARF, so the Commission on Accreditation of Rehabilitation Facilities, COA, the Council on Accreditation, DNV Healthcare, or the Joint Commission. And so we know that that also takes time to ramp up, that requirement for accreditation, and looking at the requirements for that. And so those would be implemented within 2 years. And then lastly, that evidence-based practices and principles be integrated into the service definition where possible. So there is a proposal for each agency to embed at least one evidence-based protocol in their care model. And again, a lot of this will be explained a little bit further in the presentation. So next slide. So these are the general buckets and service components and the description, and those these are draft definitions for the purpose here and then intended for the participants. And the definition of each component are posted in the document that's available for public comment, but really broadly speaking, these 8 components are for the services that we're talking about. So they'll all require initial assessments and reassessments. They'll all require some component of counseling. They'll all require strength-based treatment planning and monitoring, a plan for crisis avoidance, intervention, crisis plan development, rehabilitative psychoeducation, care coordination, restorative life skills training, and this repetition of and practice of skills developed in some of these other components. So think broadly about all of the services and sort of where they are kind of uniformly thread together. And that's all that this is highlighting here. So next slide. So what we started with is we took those 8 components from the previous slide and looked at some of our existing services. And so what you'll see here is a crosswalk of those components with the services that you're familiar with: mental health skill building, intensive in-home, therapeutic day treatment, and psychosocial rehabilitation. And so you'll see that a lot of our services already have those critical components that we're looking at. And so they shouldn't be something, not everything is going to be brand new. And so there's only a few services that you'll see on this slide, particularly that would have to include some of these additional components. So mental health skill building, for example, and psychosocial rehabilitation are really the only, and then a little bit of therapeutic day treatment, which don't meet all of the X's in all of those buckets. And so we're, using the system that we have, learning from them and how they're designed, and looking at these new service components as well. Next slide. So as many of you also know, there was new legislation that was introduced in this past session, which really tries to envision changes to our behavioral health workforce and the need to increase and make a robust system, including entry-level pathways into our behavioral health system and our workforce, as well as pathways for growing in your professional role. So that includes recent changes, including the behavioral health technician and their trainee, some changes to the qualified mental health professional structure and supervision, and then how this team all works together, how these different professional types work together is also included and envisioned here. So these activities and the services are aligned with these new Department of Health Professions regulations for QMHPs and behavioral health technicians. Within that legislation, there's also a definition for the collaborative behavioral health services in terms of how these different professionals work with each other. And so that's what's envisioned here. And so if you looked at it from a tiered component, you'll see that the behavioral health technician would provide some of the skills related to repetition and practice, and help with implementation of service and treatment planning that's done by an LMHP, and then kind of moving up from there, the QMHP role related to psychoeducation, crisis avoidance, skill building, care coordination, and the LMHP focusing on assessment, treatment planning, and counseling. So again, familiarizing ourselves with these different professional types and how they work together within these services themselves. So next slide, I'll pass it back to Lisa.
All right, thank you. So hopefully that starts to give a sense of, at the broad level, what we've learned about how other states do this is that instead of kind of having these different standalone services that are very similar but really operate as really specific things in our system, this idea of a broader service structure that can be that's available to youth and adults, that's available in the community, such as homes, as well as in centers and schools. Hopefully that kind of a general different way of thinking about it is making sense, and that you see some of the themes of our current services in those 8 components that would be in the new services. Because I know for us, it's already taken us quite some time to wrap our minds around this, as we've seen, the way that other that other states do it. Because in addition to that, in addition to thinking across youth and adults and centers and community and schools, we also are committed to having 2 tiers of service. This is something that we have, it's been really, I think it's believed the term is even mentioned in the authorizing budget language, and then it's been really echoed through the stakeholder input, that this idea of there needs to be some kind of tiering. And so I'm going to try my best to explain kind of what we think that would look like under this CPS team model. So number one, they would have different medical necessity criteria. You'll see in the document that we posted that we don't have words around this yet. We have been getting through some of the stakeholder input. We have gotten some good ideas about sort of how would you describe it? How would you describe needing access to this service in a way that doesn't require, failure from outpatient or being hospitalized? We're really trying to get at that more clinical piece of, or the functional need components, and really trying to find words. But there will be 2 different levels of medical necessity criteria for level 1 and level 2, with level 1 being more moderate intensity and level 2 being more intensive. Again, level 2, you might remember on the level of care model, the idea is that it can be a very intensive service, meeting needs at people at a very high level of need in the community. So the way that we've learned that this is done is that there's the core service component. So it's actually the 7 components. So let's see if I remember them: assessment, counseling, treatment planning and monitoring, care coordination, crisis services, crisis avoidance and planning, psychoeducation, and skill building. So those are the 7 kind of service components to start. And then essentially what that 8th component that Dr. Oplaska described, that repetition, that's essentially what changes it from being level 1 to level 2 services. And what that means, it doesn't mean that at level 1 you're not practicing. Obviously, anytime you're doing any type of skill building, you are practicing it and providing that support, training and support to make sure that somebody knows how to do it. But you can imagine that there's a lot of difference there. And so level 2 means that, and again, it might even be another professional, right? We said that the behavioral health technician role could be appropriate for this and will be allowed to do this piece of it. Essentially, this could be, could be every day that someone might need someone to really walk them through the skills and really practice out in the community, not just making a plan, for example, to walk to the bank and getting there a few times, making sure you know how to do the skill that you're working on, but it would be that more repetitive. That's what would differentiate it between level 1 and level 2. So as you can imagine, at level 2, you'd be spending more time with the member. Again, just more direct repetition, but it wouldn't actually be different activities. It would be those things that have been developed and have been being learned and supported with the QMHP, like, the crisis planning, identifying triggers, things like that, all of the restorative skill building, all of those activities. The level 2 just is essentially more repetition, more practice, more intensive, making sure that we know those, making sure that the member is able to do those skills and continue to build them up. And then I think I already got that last point that, again, someone, QMHP would be qualified to do those, but also agencies would be able to set it up to where they had behavioral health technicians out there doing that, more of the repetition, depending on the model, depending on the clients that are being served and things like that. So we can go on to the next slide. Again, this is just a little bit of a sort of, I guess you could call it a straw man, or a thinking through how it might work with the level of care model. So thinking about level 1, this could be a step down from level 2. It could be a step down from crisis services in some situations, and it could be a step down from a wraparound EBP, depending on the needs of the member. This can also be a direct step up from outpatient services, or for someone that is in longer term maintenance and their needs are increasing. And it could be a longer term maintenance support for someone with chronic needs. Whereas level 2, which is more intensive, this could be a step down from a wraparound EBP. It could also be a step down from crisis services, for example, like a residential crisis stabilization unit. It could also be a step down from inpatient or residential. So hopefully you can see a little bit of the gradation between level 1 versus level 2 and how you might step down into those. Level 2 could also be a step up from level 1 CPST, right? If the idea is they're, making some progress, but they just really need more repetition and more support to actually learn these skills. And our general thinking right now is it could be a longer term treatment. Some people will need a long period of time in this treatment, but overall our thinking is that this would not be considered a maintenance service, right? That someone would be that ultimately you would continue to meet goals at level 2, and then when you were kind of stable enough to be more at that level 1, that would be the maintenance. I will say that this part we're not quite sure on all the pieces there, but ready to get some feedback from you guys on that. So hopefully that kind of helps show a little bit of the differentiation between those 2 levels of service. We can move on to the next slide. All right. So the next set of design decisions are about the incorporation of evidence-based and trauma-informed protocols, principles, and practices. You can move on to the next one. So first, just wanted to go over some terminology. We're trying to adopt this terminology. We think that it does make a lot of sense for our system, and it will be a good way for us to all communicate about this. But it's not necessarily how we all speak yet. We usually just kind of say EBP, right? But we're thinking that this will be a helpful way for us to kind of think clearly and communicate clearly about what it is we're trying to do and how to best achieve our goals. So the first one, protocol. This is kind of the one that I'm typically thinking of when I'm thinking of an EBP, something that's packaged. There's rules about how to provide it. There might be somebody that has kind of owns a company, and they're kind of maybe the only one that's allowed to train on it. And it's very prescribed. So we're going to call that a protocol. Principles, we're going to say those are more, a little bit more broad. So it could be something like parent management training for aggression, something like that. So you kind of see that in a lot of more specific protocols, but that sort of piece of it, that module, is known to work, whether it's being implemented as part of a protocol or not. So it's sort of a principle. Practices are thinking even more broadly than that. So things like just outcome monitoring, measurement-based care, giving feedback, giving high quality supervision, and having quality improvement processes in place. And then policies would be sort of how these things are written into our rules and standards. So these could be mandates, these could be differences in rates. It can also be the development of core competencies, right? If there are some things that we think are so core and so central that we think that everyone should be trained on them and that's feasible, those could even be kind of built all the way into the service as a required core competency. So you can move on to the next one. So this is essentially, I know it's a lot of information, but this is a little bit about kind of how we're thinking about each of these 4 areas currently. And a couple of these we've touched on. Hopefully this will kind of bring those conversations together. So number 1, when it comes to protocols, I mentioned that we are looking at some standalone EBPs. We have not dug into that yet with our contractor, but the ones that we're looking at are high fidelity wraparound, coordinated specialty care, and the clubhouse model. So high fidelity wraparound and coordinated specialty care, we would consider those wraparound EBPs that would be appropriate at that high level of care, just like ACT, MST, and FFT. Whereas the clubhouse model, it could be appropriate at all levels of care, including as a long-term maintenance service. So those are, but again, we don't know whether we'll be able to implement them, but we are looking at them in the rate study. But we know that just those aren't going to meet everybody's needs. So right now, what we're proposing is that all CPST providers need to integrate at least one protocol. And I'm going to give some examples of those on some of the next slides. When it comes to the principles, oh, sorry, not yet. Let me go to that one. When it comes to the principles, some of the modules, crisis, care coordination, those do have an evidence base. So they are considered evidence based in a general sense. And also we are going to recommend this is where it gets complicated. There are 2 EBP protocols that are modular principle-based protocols. They are both on the youth side, but we think that they are very good. And again, if we require that all CPST providers do one, on the youth side, there are these 2 kind of modular principle-based ones that we think would be a really good fit for our system. When it comes to practices, like Dr. Plaska was talking about, we plan to set outcome monitoring, supervision, and caseload requirements at the agency level to do these services. And we also want to work with the health plans on new quality improvement procedures. So some of the ideas that we've learned about from other states so far include essentially practices that would decrease duplication across health plans and maybe divide the tasks up and share better information across the health plans, so that all the needs can be met, but providers aren't sort of getting the same quality oversight from multiple entities. And then policies, what we're thinking about so far, number 1 is we want to set a policy that supports referrals to wraparound EBPs as a first-line treatment when someone meets the criteria for that. And of course, if they want to have that service. We also hope to have some core competencies. You'll see those in the draft document, and we would love some feedback on those, on what training should be required across the board. And then as we build the rates, again, we're trying to require 1 EBP per provider. The costs are different, but we're going to do our best in the rate study to set a reasonable cost that could cover any of the EBPs that we want to see as of now in terms of the training and credentialing costs and building those into the rates. All right, we can go on to the next slide. And this is a little bit more straightforward. I think you guys are all familiar with this. We are going to just stick with the SAMHSA 2012 definition of a program, organization, or system being trauma-informed in terms of recognizing the impact, the signs and symptoms, being responsive, and seeking to resist re-traumatization. So we feel that we have a number of principles and practices, and then also we're going to include trauma-specific EBPs as some of the options for the EBP that is required. You can move on to the next slide. All right. So again, we are the idea is that for CPST providers, they would need to embed at least 1 evidence-based protocol. We're generally thinking maybe within a year of implementation. And this is a non-exhaustive list. It's under development. It's still being researched, all of that. But again, we wanted to go on and get the names of some protocols out there. These are ones that we heard about in the surveys, ones that we've heard about through other sources, ones that are available in our system through other funding streams currently. So did just want to go ahead and start the conversation and get some specific names out there. And of course, this is one of the things that we would like your public comments on. So you can go on to the next one. All right. So first, a couple community-based youth rehab protocols. So essentially, you can, as we're trying to shift the way that we're thinking about this, you could imagine these as if you were an intensive in-home provider transitioning to provide in-home services for youth under CPST. These are 2 protocols that we wanted to bring to your attention: free strategic family therapy and family-centered treatment. For school-based only, so again, if you were potentially a TDT provider that's hoping to transition to doing CPST in a school-based environment, one we wanted to highlight was cognitive behavioral intervention for trauma in schools, or CBITS. And for both school and community, right? So this could be for folks that provide intensive in-home or therapeutic day treatment, hoping to transition to CPST in either homes or schools. These are these 2 modular approaches that we wanted to highlight. The first one is the acronym is MATCH, ADTC. And then the second one, the acronym is MAP. And so we are still looking into these, but essentially it's sort of a comprehensive approach that allows you to use their system to look across presenting problems, right? Because we know that most youth are going to present with multiple diagnoses, multiple areas of concern, and it matches you to different modules of treatment and also provides tools to track progress over time. So we feel that these are a good fit for our system because, again, we're trying to have a broad base through these CPST services, cover the needs of youth that don't meet the criteria for one of the wraparound EBPs, and do have a broad range of presenting problems. So these are two protocols that are considered evidence-based in both school and home settings. So we wanted to draw your attention to those. And then just one example of an outpatient. So this is a very non-exhaustive list. Just wanted to give an example of, since we're going to have this counseling component, for example, a coping CAT protocol. So, an evidence-based form of counseling for youth anxiety, that would be an example of that. So I think we can move on to the next one. And well, hopefully if you have familiarity with those protocols, hopefully it makes sense how that could easily be embedded in those 7 components that we talked about, because you're building skills, you're providing counseling, some of them might not include care coordination, so you would kind of have to do that in addition to the protocol. But hopefully you can, if any of those that you're familiar with, it kind of makes sense how those, the things that are included in those treatments can fit under these broad umbrellas that we have, as far as the 7 components plus the repetition component. All right, so let me run through the same thing on the adult side. So community-based adult rehab protocol. So again, this would be if you were a mental health skill building provider or providing psychosocial rehab in a center. These are the types of protocols. I will say that I feel that we don't have quite as many on the adult side. So if you are aware of different protocols, please provide them to us through the public comment. But these are 2 examples. So for example, illness management and recovery, that's a model that SAMHSA really emphasizes, as well as integrated treatment for co-occurring disorders. And then example outpatient protocols. So one that we really want to highlight is cognitive behavioral therapy for psychosis, as well as different forms of cognitive remediation training. Then we have 2 trauma-focused therapies that could be appropriate: cognitive processing and prolonged exposure. And then for a broad-based one for adults, we want to highlight solution-focused brief therapy. As something that again, it's not going to be the whole service that somebody gets under this model, but if all of your staff were trained on that and they're providing that, that would be essentially a component of what they got. And if you're familiar, for example, with illness management and recovery, hopefully that makes sense. It's kind of it's like psychoeducation group sessions and things like that, and they kind of fit under this, fit nicely into the umbrella that CPST would provide. You can go on to the next slide. All right. So that concludes well, actually we have a tiny bit more content. Yeah, so essentially 2 things. We have the how to submit public comment, and then we have next steps. And Laura, if you want to jump in on this part, feel free to. Essentially, do you want to just do you want to just do this part? And then I'll do next steps. Okay.
Absolutely. So there is a document on our website that we would love for you to read that really goes into much more detail than we are able to do on a webinar, but really covers the topics that we talked about today. And the link to that document is in the chat. It'll go through our town hall website. And then it'll send you to our DMAS website to download the document to read. And then public comment is through the town hall website. So you'll submit your comment through the website. It is up for public comment today. It is currently up for public comment, and will come down from public comment at 11:59 p.m. on January 3rd. We understand that this is not an ideal time to be asking you to read complicated things and provide us feedback. Unfortunately, this is the time period we had, so we really appreciate anybody reading it and providing us comment during your winter break and holiday times. So that is it. And Lisa, you want to take back over?
Yeah, you can go on to the next slide. So these are just a couple questions that that would be very helpful to us. Again, when with public comment, you're able to provide whatever comment you think that you would like to provide to us. But these are a couple questions that we have. So number one, what's your opinion on the two levels, as well as what's your opinion on the activities that the different professional types would conduct? We want to know your opinion on the agency level requirements, so the supervision and the caseload requirements, and do you have any specific recommendations? So when you did the surveys, that helped us get information about your current staffing structures, so we could we're using that to estimate current caseloads. But if you have any specific ideas about an appropriate caseload, that would be very helpful. We'd like to know your opinion on moving towards the standard assessment. And any specific thoughts you have for, we know the CANS is already being used in our child serving system. So if you have any specific feedback on that, we would be glad to hear it. Also, in our stakeholder feedback, we're hearing a lot about the importance of embedding peer services in our rehabilitative services. Currently in Virginia, as you all know, we have a standalone peer benefit. So peer services are billed as individual and group services, and it can be along with any other service. But now that we've sort of described how we are proposing the CPST services would work, we're kind of curious, how do you see peer services fitting in there? Would it, for example, the options would be requiring that CPST agencies also offer peer services or also have peers on staff. So just any kind of thoughts that you have on sort of what it would mean to make sure that we're embedding peer supports. And then also, what is your opinion on the proposed requirement for the evidence-based protocol? So what's your thought on the requirement in general? And then also, what EBPs are we missing in terms of ones that you think would be a good fit for our system and maybe that you might be providing? So those are, again, just some questions to consider, that areas where we're really interested in your feedback. You can move on to the next slide. I think it might be the last one. Yep. All right, so our next steps, we will continue to work with Mercer on the standalone EBP. So again, those are the three that that we're looking at. We're also looking at targeted case management, and if there's a way to do specialty EBPs within outpatient services. So we're going to kind of keep doing that work during the public comment period. And then essentially, we will be taking the information that we learned during the public comment period, and then they're going to start the rate study. So essentially, all this policy that we've been learning about, trying to develop in a draft format, it's that information that then is used to build the rates. And so that's why we had to squeeze this public comment period in right now, because we need to have the rates developed before the end of the state fiscal year, at the end of June, so that we can have the second year of the project, which is going to be all about implementation. So again, it was the only time that we could really squeeze it in, but we feel that the changes, it's a really different way to think about it. And so we just really wanted to take a brief period of time to get some feedback. So then once we integrate that feedback and they develop the rates, we will be either posting, we'll probably do something similar, have a webinar and things like that. It'll be in late spring. And then we'll plan to have the draft service manuals out for public comment sometime summer 2025. And then, like I mentioned, year 2 is really all about implementation. So by the end of year 1, so by July 1st, 2025, we should all have a clear picture of what is going to change 1 year later. That's going to include, if you need to get new licenses, what's credentialing going to look like with the health plans, how are we going to transition the clients from the old services to the new services, and also DBHDS is working on opportunities now for provider training in terms of getting from the current services to the new services. So again, it is a fast timeline, but we are very committed to keeping year 2 focused on implementation. And so we just have to get through the planning and rate study in year 1. So I believe that is all we have. And yeah, we are so thankful for you all joining us and for taking the time to read the definitions and providing us feedback so that we can make these services as good and as updated, as evidence-based and trauma-informed as possible. Do any of our other presenters have any final words?
No, just thank you so much for joining. I know it's a lot of information. We do appreciate your input, and our teams at DMAS and DBHDS as well, who have been helping with all of this work.
All right. Thanks again, everybody. And we will be in touch and send out,
Hey,
if there's any clarifications, we'll send them out to everyone that attended the webinar. Go ahead, Laura.
We've just gotten a lot of questions about the slide deck and will it be shared. At this time, we're not going to share the slide deck. You're going to find everything that we talked about today on the public comment document, and actually much more. It's a much more in-depth, much more detailed than what we talked about today. So everything we talked about in the PowerPoint slide is in the document that's on our website. And the link is in the chat. And you can also go to the town hall website and search, and it'll come up with our public comment as well. So that is 11 page document, or maybe potentially more. So we appreciate everybody. Lisa, anything else?
No.
All right, well, I will get this posted to our YouTube channel so you guys can share it with all of your colleagues and other stakeholders, and we appreciate you. And thanks for coming today.
Thank you all.